that we're able to connect people from so many places today, and we've had a lot of success with that in the webinars in the past. But your experience as an individual may vary based on your internet connection and your computer equipment. So we have a few troubleshooting steps that we'll go over quickly if you have technology challenges today. And then if those continue, then as I said, please do go ahead and put a question in the chat box. So the troubleshooting slide is going to come up next. So one tip is if you lose connectivity or you can't hear, go ahead and close the webinar. Re-enter the meeting room in a browser other than Google Chrome by clicking on the webinar link provided. Some people have had success with Google Chrome, but we found that overall it's easier to use another browser such as Firefox or Explorer. As I mentioned, you can use the Q&A box to ask for technical support, and the support staff will try and respond to you. If, in the worst case scenario, the troubleshooting steps that you take aren't successful and you're not able to join the webinar again, the webinar is being recorded and the slides will be posted on the AIDS-Free website after the session. For those of you who've registered, you'll receive an email with a link to the recording after today's event. If you have any questions, you can also send an email to that email address there, info@aidsfree.org. In addition, the questions that don't get answered during our Q&A session will be compiled after the webinar and shared with the presenters. They'll submit their responses and we'll post those responses on the AIDS-Free website along with the recording and the slides. So to get us started now, I'm going to turn it over to our moderator for today, who's Alex Vrazo.
Thank you so much, Sabrina. Good morning, good afternoon, and good evening, everyone. I'd like to welcome and thank you for joining us today. My name is Alex Vrazo, and I'm here with my colleague, David Sullivan. We are PMTCT and Pediatric Technical Advisors in the Office of HIV/AIDS at USAID in Washington. And together, we'll present a brief introduction to set the stage on today's country presentations. So today's webinar is the fourth in our series to complement the AIDS-Free Viral Load and Early Infant Diagnosis Knowledge Base, which is a collection of resources on global guidance, country experiences, laboratory management, logistics, clinical implementation, and monitoring and evaluation intended to support the scale-up of viral load and EID programs. The slides and recordings from the previous three webinars, which have highlighted country best practices, are also available at the links below, listed 1 through 3 on the bottom of the slide there. And the slides and recording from today's webinar will also be shared by AIDS-Free. So for today's presentation, we're very excited to host colleagues from South Africa, Lesotho, and Cameroon who will be discussing best practices for improving early infant diagnosis. We first up have a presentation from Wits Reproductive Health Institute in South Africa on data-driven strategies to improve early infant diagnosis and linkage to care. Our second presentation will be from the ANOVA team in South Africa on EID in Mopani District, Limpopo, South Africa, improving linkage to care through a mother and baby tracking tool. Our third presentation will be from colleagues at EGPATH Lesotho, presenting on efforts to optimize early infant HIV diagnosis and ART initiation for HIV-exposed infants in Lesotho. And our fourth presentation to wrap us up will be from colleagues in ICAP Cameroon on a early infant diagnosis quality improvement collaborative. So to set the stage today, we wanted to highlight some global progress that's been made in preventing vertical transmission of HIV and the need for continued focus on early infant diagnosis. So you can see on the title of the slide there that you could say that for HIV-positive women and their infants enrolled in PMTCT programs, that a good beginning truly does make a good ending. The achievements of PMTCT programming in terms of positive benefits to maternal and child health in the global sphere have overwhelmingly been positive, and much praise is owed to those who have taken part in that work. So recent information from UNAIDS demonstrates really the impact of PMTCT on the changing pediatric HIV epidemic. The graph on the top right there, the small graph, shows the precipitous decline in under 15 mortality from AIDS since 2002. And the graph on the left shows some of the impact that PMTCT has had on the decline in new child infections, shown in green, since 2002, and the dramatic increase in the number of infections averted due to PMTCT in that same time period. So these successes shown on the previous slide, many of them can be attributed to rapid scale-up of PMTCT programming and expansion of Option B Plus programs globally. However, despite this increasing coverage of HIV-positive pregnant and breastfeeding women who receive antiretrovirals in PMTCT programs, which is shown in the small graph on the right, PMTCT programs do continue to struggle with timely diagnosis and ART initiation for HIV-infected infants. On the left-hand side, you can see that HIV-exposed infants are not reaping the same benefits from the PMTCT cascade as their mothers. This bar chart shows data from the 21 Global Plan priority countries. I know it's a little bit small here, and the data is from the most recent data is from 2016, but this indicates that just under 50% of HIV-exposed infants received a virological test by 2 months of age. And you can see from the graph that this number, instead of increasing, has rather stalled in the last few years. David, over to you. And do we have David on the line, or did we lose him?
I see that he's still connected, and it looks like he's speaking, but we cannot hear you, David. No, we can't hear you, David.
Okay. No problem. I can continue to present this slide until we get David back. David, we hope you'll be able to join us. So on the slide, you can see the WHO EID algorithm, and WHO recommends that infants exposed to HIV be tested at the first postnatal visit, usually when they reach 4 to 6 weeks of age or at the earliest opportunity thereafter, and that those who are infected start treatment immediately. We all know that infants infected in utero or during labor and delivery have a poor prognosis compared to those infected during breastfeeding, and they require urgent ART to prevent early mortality. However, identifying those infants using the common antibody HIV test is a challenge due to the presence of maternal HIV antibodies, which can persist for as long as 18 months in a child's bloodstream. So HIV infection can only be definitively confirmed in those infants using a virologic test, which we refer to as early infant diagnostic tests. So in this algorithm, it details that the EID test can be performed on dried blood spots or DBS specimens, which are collected at service delivery sites, and then transported and tested in large centralized labs. Unfortunately, this process often leads to long waiting periods before the results are returned to the facility and caregiver, leading to high rates of loss to follow-up, delayed initiation of ART, or even failure to start on treatment at all. And some of the presentations later today will highlight some solutions to overcome some of these barriers to care for HIV-exposed infants. Mm-hmm. I also wanted to highlight on this slide that there are, as many of us are aware, new innovative point-of-care virologic tests, several of which are now WHO pre-qualified, which have the potential to decentralize testing and therefore reduce the time taken for results to be available. On the right-hand side, there's a hot link to a WHO information note.
You hear him?
On novel points.
Yeah, I heard him too, but I don't think he can cut it.
So it sounds like we have David back on the line. So David, I'll hand over to you for the next few slides. Thanks so much.
Yeah, apologies everyone. It worked this morning at 7:30 when I first tried it. I have the pleasure of your company for 3 more slides and then for the rest of the webinar. The slide here is commenting on the challenges that Alex delineated in that important, if kind of crazy, disorienting roadmap of PMTCT for those exposed infants. And the data here are talking about how there has been demonstrable success in the early EID rates just postpartum, but longer after that 6-week test, it appears that children are getting infected during that period, which I realize the telephonic room is in tune with. It's the breastfeeding mom who passes it to her infant after successfully giving birth. So we look forward to colleagues today going forward and telling us more about it. Next slide, please. So I won't steal the thunder of those who are coming after me, but we're going to hear from presenters, for example, from our colleagues in Cameroon, identifying and acting to improve sites where turnaround time and testing coverage were suboptimal. Colleagues from Lesotho are going to talk about prompt testing, turnaround time, and initiation of ART, as well as using community organizations to assist in follow-up. South African colleagues will discuss EMR and critical hospital staff utilized to facilitate linkage and improving the continuity of care in South Africa for those exposed mothers. Next slide, please. The challenges are many in seeing a mom through to the end of all the obstacles in the PMTCT course, as we say. These can include the long turnaround times, as mentioned, poor integration of services, perhaps transport difficulties, equipment failure, maybe reagent stockouts, feelings of alienation or not feeling welcome at clinics for these infected moms and their exposed, we'll say, babies. Provider comfort in treating these children. There's a wide range, and I recognize the expertise of everyone here and know that it's a privilege to work on this stuff with you and to talk about it all today. And important for us is to help those people get over each hurdle. Those who stumble, like the woman on the far left there who's fallen over the hurdle, help her get back in the race. And critically for those infants who need ART, to get them on it. And this colorful graphic also demonstrates various aspects of this critical cascade. So my final slide here takes us back to where we started. We are grateful for your attention, your participation today, and most importantly, your good work on behalf of these women and their vulnerable infants. I will now hand over to Dr. Fick from Wits Reproductive Health and HIV Institute, who's going to talk on data-driven strategies to improve EID and linkage to care in South Africa. Thank you very much.
Hello everyone, and thank you for the introduction. And thanks to the organizers for the opportunity to present today. My name is Candice Fick. I'm here representing the Wits Reproductive Health and HIV Institute, as well as the Pediatric Adolescent Scale-Up Plan, which is a multi-partner collaboration in the city of Johannesburg that's focused on pediatric and adolescent HIV specifically. And I'm going to talk about some of the data-driven strategies that have been implemented in these programs to improve EID. Some of the interventions that I'm going to cover, the first is going to be about tracing and linking children to care using laboratory-based results reports, and then some facility-based interventions that can be used to support return of results and, of course, action for children needing treatment. So first of all, we'll talk about utilizing National Health Laboratory Services PCR results for action reports. And what are these? So in South Africa, the National Health Laboratory Service generates a weekly report. Password secured, they send it out on a Monday morning, and this is a list of all the PCR results for tests that have been done in the previous week. So it summarizes patient-level results, and it is available at multiple levels from national all the way down to the facility level. And what this really is an opportunity for us to support return of these results and also, of course, action at the facility level, as well as a useful way to monitor in terms of our testing programs and in terms of results. and this is something which has been pioneered by the lab and by Professor Sherman. The opportunities that we have, as I've alluded to, for positive and indeterminate PCR results, as well as for misdiagnostic opportunities, which are usually due to clinical errors and sometimes laboratory errors, will be easily flagged, and those children can be traced and then linked back to care or to repeat testing as required. What it also allows us to do is to compare the results list to TIA.net, which is the electronic ART register that we are using in South Africa. And then what this allows us to do is to check our results list, check our treatment list, and to see which children still need to be linked to care. One of the interventions that I'm going to describe to you now is the linkage mechanism that we have implemented by comparing these two lists to identify children that need to be traced and linked back into care. So one of the key things that we have done is we've developed an organized and standardized operating procedure for tracing children from these lists and linking them back to facilities. The list is received on a Monday. It's emailed out every week once you've registered on the Health Laboratory Services website, and then this list will be sent to clinical project managers who are in charge of a cluster of responsibilities, and also can be handed over to facility managers at the facilities. Positive patients will then be searched in the TIA.net ART register, and a list of those that are not yet initiated on treatment will be generated, and this we hand over to tracing teams. We first do telephonic tracing. Usually what we would do is 3 telephonic tracing attempts. This is done within 1 week. They would call 3 times within the week on different days at different times, hoping that they would be able to contact the caregiver for the child and ask them to come back into care. The outcomes are then recorded on a tracing tool so that we can track our processes and our progress in terms of how well we're doing with our tracing interventions. Obviously, there are some challenges, and these are linked to patients not being found in telephonic tracing. Those who are not found in telephonic tracing are then referred to the WBOTs, the WOBOTs, or ward-based outreach teams, and they are able to do community-based tracing. So they would then go to patients' homes and try to find them in the community so that they can be linked back into care. Once patients are linked back into care, or once they've been booked for a follow-up visit, we would then verify after about a week that they have actually been initiated on treatment by again checking our ART register to see if the child has been linked into care and started appropriately on treatment. These are some of the results of the tracing activities that we have implemented in the Johannesburg Health District. And the line graphs that you see are really just absolute numbers. But if I can direct your attention to the points that are highlighted in green, those are our linkage rates as we've looked at them from July last year until September 2017. And we've really got a linkage rate of about 72% on the mean, although of course we would still want to increase and maximize our linkage to 90% according to target, but really to 100% for these young children, because we know they have a very high morbidity and mortality if not started on treatment as soon as possible. So how do we close the gap? The gaps that we've identified in our intervention implementation include the fact that patient contact information is often not well captured. It's not usually captured on lab forms, as clinicians rely on clinic files and patient records. But with a highly mobile population and with patients having had their files for any number of years, these can be inaccurate, they can be outdated, and patients do move around, so the information does need to be regularly updated. One of the solutions that's being implemented by the Provincial Department of Health is unique identifiers for babies to be introduced from the 1st of January, or have been introduced from the 1st of January 2018. And those are attached on the Road to Health booklets or our child health records, so that any child accessing care in a facility has a unique identifier already, and that results can easily be traced across multiple facilities. The other thing that we've worked on is improving capturing and checking of contact information at the time when the test is done. Another intervention that is being implemented in the City of Johannesburg, central coordination at the systems level. And within the PASS program, there has been a person seconded to the Department of Health to support and facilitate tracing and follow-up of these reports so that we can ensure that they are being dealt with. Because as I'm sure you can imagine, with a report every week, if there's no one to pay attention to them, it can very quickly become a heavy burden for program staff. Cross-facility linkage. So the delivery units or the maternity obstetric units, often we found that children tested there and then down referred to other facilities. The results may not be followed up at those facilities. And I'm going to describe our facility-based intervention next. So the second component is really hospital-based champions, and that. So one of the challenges that we've identified at the hospitals, high levels of misdiagnostic opportunities, and as I've just described, poor linkage of results across facilities. The intervention that has been implemented are the EID nurses, that's what we call them, or EID champions. And this intervention, in order to decide what needed to be done, we conducted baseline assessments, identified gaps in our hospitals in the form of key informant interviews, document reviews, and then training was done for hospital staff on our local EMTCT guidelines and on dried blood spot collection. Because one of the problems that had resulted in misdiagnostic opportunities was that whole blood was still being collected at hospitals, which meant that doctors needed to draw the blood from babies, and it led to a number of process flow blockages. A PCR register was specifically developed and implemented to support this. Contact details verified on the spot for caregivers, so a cell phone number that would be recorded would be dialed immediately to see if the phone rings and we've got the right number written down. And then, of course, follow up of these results and linking these children to care for the misdiagnostic opportunities and positive and indeterminate results. So these are the results that we've had with the City of Johannesburg. And as you can see, there has been a marked increase in linkage to care of these children who are tested at hospitals and subsequently sent home and needing to initiate treatment. In the Northwest Province, which is a slightly different environment to the City of Johannesburg, which is very dense, urban and highly populated, the intervention was also implemented. And although you can see in some of our smaller hospitals, we've had a reduction in misdiagnostic opportunities, we had an initial reduction in the bigger hospital with slightly creeping up again. And one of the challenges that we might find in bigger hospitals, staff rotation, particularly if it's an academic hospital where students might be working and performing some of these tasks, that ongoing technical assistance and retraining becomes very important. Also in the Northwest Province, this is similar to the Johannesburg slide showing the linkage to care. The results here are much smaller because the Northwest is a little bit less densely populated than in Johannesburg. But you see that you can still achieve good linkage rates. Although I must add the caveat for December, where the tracing is still ongoing, that I'm reasonably sure that within the next week or so, we will have found the missing babies. So what are the next steps and what can still be done to strengthen EID tracing and linkage even more in the City of Johannesburg and then across other areas in South Africa? From our side, support and rollout of a unique identifier. And unique identifiers really will facilitate linkage across multiple facilities because for our program and in our context, birth tests are often done in the delivery unit, and those tests, it's very important for them to follow up, even though women are often discharged shortly after delivery and would follow up at other facilities to make it easy and accessible to identify those children that need to be linked to care and to treatment. Also, expansion of the hospital-based EID nurse intervention in very large hospital units, such as in the Baragwanath Hospital, where hundreds of babies are born every day. Our partners working in that hospital have found it necessary to implement daily reports to make sure that they track these babies and link them to treatment as soon as possible. Not just hospitals, but also thinking about other facilities. So we have been identifying EID champions in other large facilities in Johannesburg, and that is already in progress, and we hope to see good results from that. Obviously, always important is stakeholder engagement and implementing quality improvement processes so that we can help to build in sustainable change and ownership within the program. And then, of course, documenting success and scaling across multiple regions, support or otherwise. So thank you for your time and your attention, everybody. I would like to acknowledge colleagues within the PASS and ALMA project across the multiple partners in the Johannesburg Health District and colleagues within the WITS RHI Health System Strengthening Team, in particular the hospital strategy team, who has been crucial to implementing these interventions, and to thank them also for the great work that they are doing in supporting EID. Thank you very much. I will now hand over back to our moderator, Alex Frazo.
Thank you so much, Candace, for that excellent presentation. I want to just remind all participants to please continue adding your questions for Candace in the Q&A box for our discussion session, which will be at the end of the webinar today. The next presentation is from Dr. Lucy Renoto of Inova Health, who will discuss the use of a mother-baby pair tracking tool in South Africa. Lucy, over to you. Lucy, just checking that you are there. We can't yet hear you. Okay, looks like we might be having a few technical difficulties getting Lucy online. We know she's in the presentation window, but we cannot yet hear her. Lucy, let's just do a final check to see if you are still on mute. Okay, we still can't hear you. Shall we go ahead and move over to Dr. Esther Tumbare's presentation from Lesotho? And let's see if we can get Esther as well on the line. Just make sure if you are a presenter that you go ahead and unmute your mic. And Esther, it looks like you're unmuted, but we can't yet hear you. Oh, I think we can hear you, Esther. Okay, do we either have Esther or Lucy on the line? Okay. Well, I think...
Hello?
Oh, hi. And who is that? Hi, we can hear you.
Can you hear me now? This is Lucy.
Oh, hi, Lucy. Wonderful.
This is Lucy from Inova.
Wonderful. Well, thank you all for bearing with us. I think this, highlights the amazing possibilities of webinar technology that we are all able to bring colleagues together, but it also highlights some of the challenges in getting everyone connected. So thank you all for bearing with us, and let's turn back over to Lucy Renoto from Inova. Thanks, Lucy.
Good morning, good afternoon, good evening, everyone. I am Lucy Renoto. I am the Limpopo Provincial Program Manager from Inova Health Institute. Inova has been supporting Mopani in various programs since 2004, but with intensified PMTCT support for about 13 years now. Currently, our PCR positivity rate is less than 2%. During the maternal and mortality reviews in Mopani, it was found that approximately 40% of the maternal mortality was due to HIV-related factors. One of the reasons was challenges around the follow-up of HIV pregnant women from the time of booking to delivery. When the rationalization of registers was introduced in South Africa, most of the registers, including the ANC register, were replaced by the daily PHC tick register. This made it very difficult to follow up a cohort of patients, tracking them from booking to delivery, as well as linking the HIV-exposed babies to their mothers. The Mother Mentor program was introduced, but because of the hierarchy within the clinics, there was a disconnect between the Mother Mentor program and professional nurses managing the HIV pregnant women. Initially, Tia.net was used, but there were challenges as it could not identify women that tested positive while pregnant. Those were the only women that could be identified. The ones that fell pregnant while on ART, we could not identify them on ART. So as per request from the district clinical specialist team, ANOVA worked with the team to find a way to effectively monitor the management of HIV pregnant women and link the exposed babies to the mothers. The aim was to develop a simple tracking tool that will track the mother and baby pair from first ANC visit to 18 months of HIV testing. It was also to simplify PMTCT tracking at PHC level. It also allows easily monitoring of the clinical progress of the mother, allows linkage to care of all HIV positive babies, and it also allowed the managers to easily monitor the program. The next coming slides, 3 slides, show how the tracking tool looks like. The picture on your left shows the outer cover of the tracking tool. The inside of the outer cover shows the guide on how to complete the tracking tool. Each page, on the left side of each page shows the mother's details, and on the right side shows the baby's details. It covers them, with the mother's details, it covers all the details for us to be able to trace the mother, including the caregiver in case the mother is not there. It covers linkage of mom to ART program. It also documents the gestation at the time of booking. It shows IPT prophylaxis collection up until completion of IPT prophylaxis. It also shows ART collection schedules of a mom. It shows a viral load monitoring schedule. The right side of each page is a baby section. It covers infant prophylaxis, including cotrimoxazole at 6 weeks, which was difficult to monitor because we did not have any register that would document cotrimoxazole at 6 weeks. It covers infant testing from birth to 18 months. It allows linkage to care for all the HIV positive babies. The outer cover of the tracking tool shows the viral load section where you can be able to follow how to monitor the mom, the viral load schedule according to South African guidelines. The implementation of the tool started in June 2017 in 105 PHC facilities. To evaluate the implementation, the plan was to do an assessment before and after the rollout of the tool. We attempted to collect baseline data, but it was virtually impossible as we had to search through multiple records. In some instances, some of those records were missing, so we could not get much from the baseline data. From the tracking tool, we evaluated the implementation from July up until November 2017. The data sources that we looked at, we used the District Health Information System to get the number of HIV-positive pregnant women that were booked between July and November 2017. We used the HCT register to identify newly diagnosed HIV-positive pregnant women. We used the PHC tick register to identify known positive pregnant women, and we used the tracking tool to compare the HIS HCT register, the tick register, with what's documented in the PMTCT tracking tool. We also looked at the longitudinal tracking of mother and baby pairs. The key results, the slide that you're looking at right now, on your left, it's a bar graph. The gray graph shows all the number of HIV positive pregnant women that were recorded on DHIS. The dark blue shows 57% of those that were recorded on DHIS were actually recorded in the tracking tool. The light green shows 83% of those that were in the tracking tool had documented viral load in the tracking tool. The graph on the right side, the pie graph, shows viral load suppression as documented in the tracking tool. Of the 103 women we found in the tracking tool, 72% of them were suppressed and 28% of them were not suppressed. So the PMTCT tracking tool has been implemented for 4 months now. It usually takes time for a new tool to be implemented. So 57% of women that are documented in the tracking tool, it's actually a success to us because it shows that if we implement it longer, we can be able to document all our HIV positive pregnant women in the tool and be able to follow them up. The tool makes it easier to also follow the viral load results. As before, you would have to go through the ART file, page through the ART file so that you can get a series of viral loads for one patient, and that was tedious. It took time. The graph on the left shows ART prophylaxis, cotrimoxazole prophylaxis for the infant. It also shows infant feeding as documented in the PMTCT tracking tool. The number of women HIV positive documented in the tracking tool were 104. 73% of those had a delivery date documented. So we could only follow 73% that they actually delivered as they had a delivery date. 63% of those babies had ART prophylaxis given at birth. 54% of those were given cotrimoxazole at 6 weeks, and infant feeding was recorded for 60% of those. The pie graph on your right shows the different modes of feeding within 6 days of delivery. We can easily see that about 8% of the babies were exclusive formula feeding, about 3% of them were mixed feeding, and 87% of those babies were exclusive breastfeeding. Initially, we couldn't have this information in one document. You had to go through a series of records for you to get infant feeding, if you'll get it at all. Most of them were recorded in your Road to Health cards or in your ANC cards that are patient held. You could not find them at the clinic. This slide shows tracking of early infant diagnosis. It also shows loss to follow-up of these infants. Of the 76 entries that we found that had a date of delivery documented, those 76, we expect them to be eligible for a BET PCR. 95% of those babies had a PCR recorded in the tracking tool. 60 of those babies, the results were recorded in the tracking tool and they were all negative. At 10 weeks, we had 67 of them that were eligible for PCR. 84% were taken, were collected PCR at 10 weeks, and 45% of those collected had a negative PCR. When you look at our 18 weeks, it's quite low because not everybody is eligible for that, but of the ones that are eligible, 9 of them were collected, which is 64%. The 18 months testing, we don't have it here because the cohort has not reached 18 months yet. The tracking tool is only 4 months in the facilities. So you can see the tool makes it easier to trace the babies and the moms if they did not come for PCR. As we showed initially that we've got details that would trace the moms and that would also trace the caregivers if the babies did not come for testing. So limitations to the evaluation tool, tracking of the babies beyond 18 weeks, like I said, wasn't possible because the tool is just recently being introduced. Most deliveries are done in hospitals and some of the clients are lost in between the hospitals and the PHC facilities. So this tells us that we need to now strengthen the referral pathways between the hospitals and the clinics so that we don't lose any babies or any moms in between. In the new tool, we can see that a lot of women were not documented, almost 43%. Like I said, it's a new tool. We still need to strengthen the referral pathways between the hospitals and the clinics. What we can learn from this is the tool is easy and very efficient. It can be used by all the healthcare workers in the facilities, including non-clinical staff, your lay counselors, your mother mentors. The tracking tool promotes continuity of care for both mom and baby pair in one register. It improves clinical care of the mother, hence low risk of HIV transmission to the baby. It improves guidelines to early infant diagnosis. Our recommendation is the development of electronic records where you have TIA.net PM2CT module, which will link the mom and the baby pair. You'll be able to draw up reports that you are able to monitor and check if the babies have been tested according to the schedule. For those ones that are positive, you are able to put them on treatment. For those ones that are lost to follow-up, you are able to trace them immediately. We also recommend the implementation of the unique identifier for both mother and child to strengthen tracking. And we would like to acknowledge USAID, Limpopo Provincial, Mopani District Department, and the ANOVA team. Thank you. I will now turn the presentation back to our moderator, Alex.
Great. Thank you so much. That was a fantastic presentation. I want to encourage everyone to keep on adding their questions for Lucy and the ANOVA Health team into the discussion box, please. And now we will go ahead and turn it over to Esther Tumbare, who will be presenting on EGPATH efforts to optimize early infant HIV diagnosis and ART initiation for HIV-exposed infants in Lesotho. So, Esther, over to you. Okay, it looks like we might still be having a bit of trouble in having Esther join. Let's see if she is able to join in the next 10 seconds or so. And while we're waiting for Esther to join, I'll also just check that Jillian and Tinjay are queued up to present in the event that we can't connect with Esther. So we'll just give it a couple more minutes. Thanks, everyone, for your patience. All right, Esther, I don't think we're hearing you, unfortunately. We'll try and connect with you for the last presentation. Tinjay and Jillian, are you there? Hi.
Esther is trying to connect. You can talk.
She is. Wonderful. Okay.
Hello. Maybe I can speak from the Skype and you can advance my slides for me?
Yes. Hi, Esther. We can hear you loud and clear. Very happy to have you back.
Okay. Thank you. Can I start?
Please go ahead and just indicate next slide when you're ready for the next slide. Thank you.
Okay, first slide. So it's my pleasure to give this presentation on the efforts being done by ECPAF to optimize early infant diagnosis in Lesotho and ART initiation for HIV-exposed infants. Next slide. I will just start by giving a brief overview of the epidemiology of HIV in Lesotho. We have a population of slightly over prevalent rate of about 300,000 people living with HIV and 13,000 children living with HIV. Adult prevalence is, currently stands at about 25.6%, and for pediatric patients at about 2.1%. According to the UNAIDS 1990 targets, the LEFIA results that were done recently show that we are currently at 77 for the first 90, 90% for the second one, and 88% for the third 90. We have about slightly over 8,000 women receiving PMTCT services annually, and we've done pretty well with our maternal-to-child transmission rate, and it currently stands at about 4% at 6 weeks. Next slide, please. So as far as our support from ECPAF is concerned, ECPAF has been in Lesotho since 2004 and is the main clinical partner to the Ministry of Health. And our current focus is in all 10 districts in the country where we are providing direct service delivery for comprehensive TB and HIV services, with funding coming in from USAID, CDC, and UNITAID. As far as EID is concerned, we do track all infants who are HIV exposed, as well as collection and submission of early infant diagnosis samples for processing through the centralized conventional lab system, as well as point-of-care early infant diagnosis. We also provide return of results and ART initiation for infants who test positive. Next slide, please. This next slide just basically shows what was happening between the years of 2014 and 2016 as far as turnaround time for early infant diagnosis is concerned. This is data from CHAI with a sample size of about 18,700 infants. And as you can see from the slide, the turnaround time was quite long, ranging from about 30 days to 94 days for between the time the sample was collected and the time the result was returned to the health facility. Next slide, please. So going on to the point-of-care early infant diagnosis project, the goal of this project is to increase the number of HIV-exposed, HIV-positive infants whose HIV status is known, and to facilitate early ART initiation in these infants. The purpose, of course, is to ensure that at-risk infants have timely access to HIV testing through scale-up of point-of-care early infant diagnosis in the context of optimizing already existing national EID networks. This is a project that is being run by ECPAF in 9 countries, including Lesotho, and started in 2015 and is due to end in 2019. Next slide, please. So just to describe this project, we did start with site selection with sites located in all 10 districts in the country. We looked at sites that have access to ART initiation because we did want these infants to then be immediately linked to ART initiation if they were found to be positive. And also sites that have a relatively large number of infants, HIV-exposed infants being seen, at least 0.5 or 1 test to be done per 2 days. We were opting for the hub and spoke model, which I will describe in future slides. And we matched these slides to either the ALIRQ model or the CEPHAID expert model. We were planning on doing a phased and monitored implementation with a 6-month pilot phase, which was then followed by implementation and evaluation of key clinical and service delivery outcomes, comparing what was being seen through point of care compared to conventional EID. And so the data I'll be presenting today incorporates data starting from January of this year, of 2017 to October of 2017. Next slide, please. This slide basically just shows you where exactly the sites that will benefit from the 29 test machines that will be deployed in Lesotho will be situated. And as you can see from the slide, this is for all over the country. For the pilot sites, we were looking at 5 pilot sites in different districts. 2 of the machines were going to be standalone machines, whilst the other 3 were going to be hub and spoke. But ultimately, the country would be able to reach 155 sites through the hub and spoke model. Up to date, about 14 of the 29 machines expected in the country are already operational. Next slide, please. So this slide just basically describes what a standalone model would look like. It would process samples that are coming from the facility where it's stationed, whereas the hub and spoke model would include samples coming in from the site as well as surrounding health facilities in the nearby vicinity of the site. Next slide, please. The baseline, before we started the pilot, we actually did a baseline just to see what was currently happening in the country at the time. And as you can see from the slide, looking at tracking 269 samples that were being processed through the normal conventional lab system, 82% of the results from these babies will actually reach the caregiver. The median turnaround time was quite long. It's about 63 days, but ranging from 13 to 161. And 7 out of the 8 infants who were found to be HIV infected were initiated on treatment. What was good was that of those that were initiated on treatment, that was done on the same day as the caregiver came to the health facility to collect the results. Next slide, please. Going on to look at the results for the primary outcomes, and as you can see from the slide, as I said, these are results ranging from January to October of 2017 with 31 unique health facilities. We tested slightly over 1,800 tests. And with 1,500 plus infants. Of course, some of these tests were for infants, repeat tests for infants according to our national guidelines. And looking at the actual results, the return of results was quite high at almost 100%, 99.9%, with a median turnaround time of 0 days, range of 0 to 38. And 31 of the 33 HIV-infected infants were actually initiated on treatment. The median number of days between receiving the results to the caregiver and initiation of treatment for the baby was also 0 days. So these are quite good results. The next slide just basically shows how many of the tests that were done reached the caregiver on the same day and on subsequent days. And as you can see from the slide, the great majority of the results were given to caregivers on the same day, about 64%. And the rest of the 36% of the results that were not given on the same day were those that were coming in from the spoke sites rather than from the standalone or the hub site. But all in all the results were actually given to the caregiver. Next slide, please. Going on to talking about tracking of results. LENASO, Lesotho Network of AIDS Services Organization, is a civil society organization who is a sub-partner of ECPAF under 2 of our awards, the PUSH and the STAR-L PEPFAR awards. They are also supported by AIDS-Free for technical and organizational capacity building, and are mandated to do community linkages and community mobilizations in the community. So they routinely track all infants who miss their appointments for early infant diagnosis in the community. And as you can see from the slide, the successfully tracked outcomes are quite good. It's almost 70% of the infants that they tracked between the period of April to September of 2017. Next slide, please. The next slide just basically shows some of the data that is coming out of the 5 scale-up districts supported by PEPFAR that ECPAF is supporting. And as you can see from the slide, we were through both the point-of-care early infant diagnosis and the routine lab-based machines, were able to reach our target for virological testing of infants within the first 12 months of life. It's 92% achievement of the target. And of those expected to be positive, we also reached 90% of that target, with a positivity of about 1.5% overall. Next slide, please. And so looking at the remaining challenges as far as point of care, as far as early infant diagnosis is concerned, because of the limitations of funding that we have from UNITAID, we are only able to service some of the existing sites in the country. The country does have over 250 sites where HIV services are provided, but from previous slides you could see that we are only going to be able to service about 115 of these sites. The turnaround time for early infant diagnosis does remain quite long in some of our health facilities because of the centralized processing of samples through the National Reference Lab. And collection of the samples from the health facilities is also problematic, as the transport mechanism only collects samples on specific days of the week, maybe once or twice per week. LENASO does track infants who default early infant diagnosis, but sometimes even when the infants are found in the community, they do not present for testing, and the caregivers cite all sorts of challenges such as transport problems and the unavailability of the legal caregiver to provide consent for testing. Some of our parents do still refuse for their infants to be initiated on treatment, despite extensive counseling that is provided. And there is some worry about the sustainability of the point-of-care early infant diagnosis following the end of the UNITAID grant. We have been having discussions with Global Fund to see if this Global Fund can take on the supply of maintenance of the machines, as well as provision of the consumables following 2019 after the end of UNITAID. We also consistently find that we are only reaching 70% of our population level coverage for PMTCT. We are not sure what is happening with the other 30%, whether they are being seen in private health facilities or crossing over the border to South Africa. But over the years, we have remained at a PMTCT coverage of only 70%, and this is quite concerning. So looking at the conclusion, I think it's fair to say that point of care does show improvement over conventional centralized testing in service delivery outcomes, such as a greater proportion of infants obtaining their results. The results were received for the majority of infants on the same day, rather than having to wait for prolonged periods. A high proportion of HIV-positive infants were also started in ART, and same-day ART was still maintained without any delay, even with point of care. The cost that is calculated is also almost the same if you compare conventional EID with a point of care EID. And finally, we demonstrated that the use of CSOs working in collaboration with other community-based organizations is an effective way of increasing EID uptake for HIV-exposed infants. Thank you so much for listening. I'll hand over back to the moderator.
Thanks, everyone. Some excellent presentations thus far from South African colleagues and colleagues from Lesotho. The combination of technology and really persistent people to get a job done, I think, is demonstrated by today's webinar and the men and women on the call. So to borrow a phrase from our next presenters, Tinjay and Jillian from Cameroon, on est ensemble, we are together. We go north to our colleagues from Cameroon. Thanks.
Thank you, Alex. Hello. This is Tinjay.
Hi, Tinjay. We can hear you. Please go ahead.
Okay. So you're going to be assisting on the presentation of the Early Infant Diagnosis Quality Improvement Cooperative implemented in Cameroon. And quickly, we are going to walk through the outline, which consists of why Cameroon selected a quality challenge on early infant diagnosis. We are going to see what the Quality Improvement Collaborative approach is, its design, the process, the results, and we'll see our conclusion. So early infant diagnosis services were launched in Cameroon since 2007 and constituted an evidence-based package of services and was a standard practice at many of Cameroon's health facilities. But performance and compliance with national guidelines was often suboptimal. At many health facilities, fewer than half of children were tested, and this was due to programmatic barriers such as workload, staff training, availability of test kits, and other service delivery challenges, which were going to be addressed by quality improvement interventions. In addition, a National AIDS Control Committee survey, which reported that the follow-up of HIV-exposed infants was weak countrywide in 2012, prior to the implementation of quality improvement projects. And this same survey found out that only 12% of these HIV-exposed infants had appropriate HIV testing at the recommended 6 weeks of age. So ICAP also performed an assessment at 64 health facilities which were being supported by ICAP, and the report revealed that the average turnaround time from this assessment exceeded 6 weeks at 73% of the sites, of these 54 sites, with a median turnaround time of up to 3 to 4 months, which was far longer than the national standard of 4 weeks. So there was clear evidence and existence of a nodal gap between what could be done and what was actually done at Cameroon's health system. So through PEPFAR or QICIP mechanism in 2015, ICAP launched a quality improvement collaborative focused on improving early infant diagnosis at 17 health facilities of the central and littoral regions of Cameroon. What is the quality improvement collaborative approach? It is an organized network of sites which can be made up of districts, facilities, or communities that work together on a focused program topic area using quality improvement methods and tools. And in our context, our program topic area was early infant diagnosis. Typically, these sites work together within a limited time of 12 to 18 months, during which we share in statements, indicators, and measurement processes within this period. They also organize regular forums for data review, shared learning, and spread successful change ideas. And these regular forums are usually organized on a quarterly basis. What counts for the quality improvement approach is the final harvest meeting of successful interventions and tools, as well as resources. This is a schematic representation of the quality improvement collaborative approach adapted from the iHigh Breakthrough series. So it starts with selection of an aim, and our aim was to improve early infant diagnosis. Then later on, we convene an expert meeting to identify best practices, develop aim statements, indicators, and data SOPs. Sites are later on selected and prepared, which is followed by a learning session, which is the crucial learning session, the first one, and it's during this learning session where QI sites that have been selected are trained on QI methods. After each learning session, we have what we call an action period, which usually lasts 3 months. So each learning session, as we earlier said, takes place on a quarterly basis. And during the action period, teams perform quality intervention activities based on the Plan, Do, Study, Act model, which we can also simply call PDSA model. And the quality improvement interventions are documented on quality improvement PDSA worksheets that were handed out to these quality improvement teams. So in our quality improvement collaborative, we see that we have 5 learning sessions. And at the end of the learning sessions, we have a harvest of successful change ideas, successful QI interventions, and tools which were based on scientific analysis. After the successful interventions have been identified, they are later on scaled up to other sites and spread through via dissemination meetings and many other dissemination venues. So designing a quality improvement collaborative starts by selecting a site, selecting a quality challenge, developing an aim statement, selecting the indicators that will speak to the aim statement, developing a data management system, collecting baseline data and analyzing this data, and convening a baseline meeting where we will present to stakeholders what has been found at the baseline and what we are aiming to achieve after quality improvement interventions have been implemented. The 17 sites of the quality improvement collaborative was selected based on PEPFAR priority health facilities and PEPFAR priority regions in Cameroon. These were the littoral and the central region, and these 17 sites were identified as sites yielding a larger volume of HIV-exposed infants. The aim statements of the Quality Improvement Collaborative in Cameroon were in 2 sets, were defined in 2 sets. The first set was at the period of March 2016 to March 2017. And the first aim consisted of improving early infant diagnosis from baseline to more than or equal to 50% of HIV-exposed infants who had their dry blood spot PCR test results documented and shared with caregivers. The second aim was to reduce the average time when samples were collected to when these results were documented and shared to caregivers to under 6 weeks or 42 weeks. After implementing QI interventions 5 months into the Quality Improvement Collaborative, we realized that this first set of aims was achieved sustainably in the 7 last months. By March 2017, we achieved all the aims, and so this led to the adjustment of aim statements in April 2017. So instead of 50% GBS PCR test results documented and shared to caregivers, we now decided to adjust it to 90%. And instead of a turnaround time to under 6 weeks, it was adjusted to a turnaround time of under 2 weeks or 14 weeks. The EID cascade process map enabled the indicator development process, which was the first step in having our data collection element. So the cascade of the process map consisted of the following steps. Firstly, the baby arrives at the clinic, is identified as an HIV-exposed infant. Then the sample is collected. The next step is when it's sent to the referral lab. The results are received from the referral lab to the facility, at the facility lab, then shared with the caregiver. And based on the results that we sent to the facility lab, if it is an HIV-positive infected, HIV-infected infant, the infant is going to be initiated on antiretroviral treatment in the care and treatment unit of the facility. So we also have what was peculiar to our early infant diagnosis quality improvement collaborative, the time indicators, which enables us to measure the times at the different steps of the early infant cascade process. Data was managed on VHIS teams, and when data was collected by the QI teams at the level of the site, they enter the data directly into DHIS using tablet IT devices. On the left side of your screen, you see the data entry form capture on DHIS. Once the teams enter this into the DHIS form on enter the data and submit it, automatically on the right side of your screen, you see how the dashboards were generated automatically, and this enabled the teams to have quality improvement meetings during which they were able to analyze the data and decide whether their quality improvement intervention was actually bringing an improvement or not in early infant diagnosis. Implementing a quality improvement collaborative starts by designing a baseline training package on quality improvement methodology, followed by training of site-level QI teams at learning session 1. After the learning session, the initial learning session, when the teams have the capacity to implement quality improvement intervention based on the methodologies that were transferred to them during the training, they launch QI activities at each site. Monthly supportive supervision were conducted during the action periods to coach these teams in identifying quality improvement change interventions, and during the learning session, they came back and shared their change interventions after every quarter. 5 learning sessions were conducted during the implementation of this quality improvement collaborative, and the main activities consisted of site-level data review from each of the 17 health facilities. Change ideas, successful intervention tools and resources were exchanged among teams, and it was also an opportunity to refresh the QI teams that were coming for the first time, or when they had some teams had to change in personnel on QI methodologies. And this was the case of the February learning session, February 2017 learning session. Monthly supportive supervision visits included Ministry of Health staff, and the QI team recorded change interventions during these supervisions on PDSA worksheets and on RUNCAP worksheets, as you can see on the picture on the right side of the screen. So ICAP team at Cameroon country level compiled the 5 report findings and shared with the team at New York headquarters, in ICAP New York headquarters. QI teams conducted 146 PDSA cycles and identified approximately 30 successful change ideas during the harvest analytical phase. ICAP staff made 272 supportive supervision visits to provide coaching, mentoring to the site-level QI teams. The learning session participation rate was high. In general, we had between 56 to 69 participants attending each learning session meeting. We have more and more HIV-exposed infants who were tested at the recommended age according to national standards and guidelines. So the blue trend, you see how there were, after baseline data, from baseline data to when QI activities were launched in February 2016, we have more HIV-exposed infants tested before 8 weeks of age. The proportion of HIV-exposed infants tested with GBS PCR results documented and shared with caregiver also improved almost immediately after QI activities were launched in February 2016. From baseline data, you can see how low this proportion was, and after QI activities were launched in February 2016, it improved in the month of April, and target was achieved. And this continued through to May 2017. And there is a reason why there was a drop in this trend in May 2017. This is because in the EID cascade process, there was a breakdown at the level of the referral laboratory. One of the referral laboratories had a breakdown in power supply due to a storm, and the other referral laboratory had a breakdown in the equipment. So there was no results that the results that returned to facility lab in the month of May were low, and so there was little documentation and sharing of results with caregiver within this month. In the time cascade of the EID process, the blue bars represent the time from when samples were collected to when they were sent to the referral lab. So the QI activities reduced over time, led to the reduction of the time as time went on. And the red bars represent the time from when samples were received at the referral laboratory and processed before sending to the facility lab. As you can see, from February 2016, the trend, the sizes of the red bars reduced over time to achieving the target. And the green bars represent the time from when the results were received at the facility lab to when they were shared with the caregiver. And this also improved remarkably as QI interventions were ongoing. EID Quality Improvement Collaborative brought sustained improvement as time went on. 16 of the 17 sites reached the coverage target of 50% and more, and on average this took only 2.5 months to achieve the target. All the 17 sites reached and sustained the turnaround time target of less than 42 days, and even when this target was revised to 14 days, they continued to improve the turnaround time. In conclusion, the Quality Improvement Collaborative addressed a critical quality challenge which was aligned to national and PEPFAR priorities. It was directly relevant to the first 90 and aligned with the monitoring and evaluation reporting indicators and SIM core evaluation elements. The approach was systemic and rigorous, inclusive of multiple stakeholders, robust M&E and data quality assurance processes, with the innovative use of DHIS in managing quality improvement data. Dr. Nomo Ekene Marshall, Director of IOS Regional Hospital, said, thanks to ICAP support, our nurses are more available to patients. There's reinforced capacity, and we have stronger ties with our community. Another doctor, Dr. Estomba Roland of Akono Linga District Hospital, said ever since quality improvement activities were implemented at the level of his facility, he never recorded any HIV-exposed infant death. And so, thank you for your kind attention. I'll now hand over to Alex for the next phase.
Great. Thank you so much, Tinjay, for that wonderful presentation. It's fantastic to see some of the improvements from the Quality Improvement Collaborative that you highlighted from Cameroon. So we will now use the rest of the time today for discussion. As you can see, we only have about 10 minutes remaining for today's discussion, but we have a lot of questions in the chat box. So the questions that we are not able to get to in the time that we have remaining, we will collect and we will ask the speakers to share their responses. The responses will be posted on the AIDS-Free website with the recording and the slides following the webinar. So if you have a question and you haven't yet entered it into the Q&A box, please do so now. So, Sabrina, I think you're going to pose the first question.
Yeah, our first question is directed towards Candace, who did the first presentation from South Africa. The question is in regards to what is the selection criteria for the EID champions? So Candace, please take it away.
Thank you, Sabrina. So the selection criteria, usually we would select someone who is a professional nurse working in the postnatal ward, especially with infant care, because these nurses will be having some EMTCT exposure or responsibilities anyway. But I think probably the most important selection criteria among this group of professionals is someone who is passionate about EID and someone who is willing and able to take on some of this responsibility in terms of their allocation, in terms of their time. So we have had our EID champions being senior nursing staff. We have had some more junior nurses who just feel like it's really important and that that's something that they should be doing. So what the real most important selection criterion I would say is someone who's passionate about EID and who's willing to put in some extra effort to make sure that the children are linked to care and treatment. Thanks very much.
Wonderful. Thanks so much, Candace. Our second question goes to Esther. This question is from Fatima Sourif in ICAP Columbia University. Fatima's question is, did you see an increase in EID coverage with rollout of POC, i.e., did the number of expected HIV-exposed infants who were tested improve? There is some concern that while POC has improved the turnaround time for results and timely ART initiation, overall testing coverage is only improving, slightly indicative of more upstream challenges such as poor retention in pregnant women and subsequent enrollment of HIV-exposed infants. So, Esther, over to you, please. Thanks.
Okay, hi, thanks for that question. Actually, we have seen a huge increase in the coverage for testing for infants and for timely initiation on ART. The fact that we have point-of-care early infant diagnosis machines in some of the sites has reduced the load for the National Reference Lab in processing samples. And even from the results that I shared, looking at the targets that were set and how we have achieved the targets, we're seeing a huge increase in coverage for EID. As far as population level coverage is concerned, I think that is something that we still have to investigate and find out where these pregnant mothers are. But as far as mothers coming to the health facility to access PMTCT, I think as far as EID is concerned, we're doing quite well. And the few numbers of infants that are testing positive because of the successes of PMTCT are being timely initiated on ART with same-day initiation. Did I answer that question correctly? I mean,
yes,
adequately?
Thanks, Esther. Thank you, Esther. Yes, that was very helpful. There are a few more questions still remaining. Let's turn over to a third question. So the next question is for Dr. Lucy. And this question comes from Rachel Abenacchio. And Rachel's question is, Dr. Lucy, what suggestions would you give to countries, in your experience, where most deliveries are out of the health facilities and babies only get a chance to contact the health facility after they've had an episode of illness? Rachel also mentions that some mothers opt to deliver from their homes for several reasons. So I'll pass that over to Dr. Lucy. Thank you. And I hope we still have Lucy on the line. I know we have been bearing with a couple of technical challenges during our webinar today, and everyone's been bearing with those very, very nicely. So I don't seem to hear Lucy. So why don't we? Oh, hi, Lucy. Go ahead. Lucy, are you there? Would you like to answer that question? Okay, I think we might have lost Lucy again, but Lucy, we'll make sure to send you that question so you can answer it, and your answers can be posted online. So I think let's go over to another question, this one also for Tinjay. We have a couple questions around the quality improvement initiative. David Jameson asks,
Hello?
So Tinjay, did you experience any resistance to change at the facilities? So over to Tinjay.
Can you hear me?
Hello, please, can you comment? The network was perturbing.
Can you hear me?
Yes, hello, I can hear you. Yes. Hello?
Okay. Is that Tinjay or Lucy? Hi.
This is Tinjay.
Oh, hi, Tinjay. Okay, please go ahead. Could you please answer the question regarding whether or not, from David, regarding whether or not the quality improvement collaborative experienced any resistance to change at the facilities? And I think this will be the last question before we wrap up. Thanks, Tinjay.
Thank you for that great question, David. I would say that we didn't really experience any resistance to change with the authorities because the approach of the quality improvement methodology consisted of buying in the leadership before any quality improvement interventions were implemented. So you see, at the beginning, we started with a stakeholders meeting, presenting to them why it's important for us to bring about improvement and quality improvement interventions. And throughout the process, they were very involved, and I think this addressed the risk of facing any resistance at the level of the leaders, at the central level as well as at the facility level. I hope I answered the question.
Yes, that's great. Thank you so much, Tinjay. Over to Sabrina.
Yeah. Thank you, Tinjay, and thanks very much, Alex, for moderating those questions. As Alex had mentioned, there were a number of questions that we received in the Q&A box, and so thanks to all of you for asking those questions. And we will be filtering out the questions that didn't get answered today. We'll be sending those out to the appropriate presenters, getting their responses, and then posting those on the website afterwards. You'll get an update when the recording, the slides, and the responses to questions are up on the website. So before we wrap up today, we want to thank, first of all, the speakers who have shared their time and their expertise today. I think we can all agree that we heard some excellent presentations today. And thanks to everybody also for being patient and very calm during all our technical challenges. And thank you most of all to the participants for attending and for your questions and for the discussion. One thing I'd like to ask of folks before everybody signs off, please take a moment to fill out the poll questions that you now see on your screen. The feedback on those questions will help us to improve future webinars and determine topics and make sure that these webinars are really responsive to your needs. So please do take another sort of minute, maybe even 30 seconds to fill that out. Please also today and in the future, you're encouraged to go ahead and visit the A3 Viral Load and Early Infant Diagnosis Knowledge Base. We have over 180 tools, publications, and other resources that can help you scale up viral load testing and EID. You can sign up on the A3 website as well if you'd like to receive updates on the knowledge base, and we update that pretty regularly on a monthly basis, actually. And as I mentioned, you'll be getting an email today when the recording and slides and the question responses are available on the A3 website. Thank you again to everybody for joining and sharing your knowledge today, and have a great day.